Good evening, everyone. And this is a subject we should actually be shouting about, as we saw in the previous session. Unfortunately, TB is the silent killer in India. 2.7 million people get TB every year in the country. And that's almost a quarter of the total TB cases across the world. Every year, 4 lakh people, 400,000 people die of TB. And again, India tops the list in the number of deaths caused by TB across the world. That they actually account for a third of the people dying of TB. Even more worrying is that India has the highest number of drug-resistant TB. And there are two forms of that. One is called a multi-drug resistant, and we also top on what is called extreme drug-resistant TB. And more importantly, TB has become the great leveler. We always thought it was a disease of the poor, of the slums. It has affected every single community, whether rich, middle class, or the poor. And so we have a very eminent panel to discuss this subject, and not in any particular order, but Dr. Lancelot Pinto, consultant pulmonologist of the Hinduja Hospital, Dr. Sudhakar Shinde, who's additional municipal council for BMC. And by the way, Mumbai is probably, is not a very good thing to say, but the TB capital of India. It has the highest number of cases. We have Raman Sankar, the Senior Director, Global Health Strategies. And we have a TB survivor, Meera Yadav, TB champion as well. And she's had a tremendous sort of experience with that unfortunate experience where she will narrate later on. But let's start with you, Dr. Lancelot Pinto. What is the reason for this resurgence of TB that you see in India? What is, we had TB for ages, but why now?
Thank you, Raj. And I think it's a great initiative that India today is acknowledging the magnitude of the problem. I think one of the biggest myths and lies that individuals tell themselves when it comes to tuberculosis is that it will never happen to us. There is this perception that it happens only to the marginalized and the impoverished. And while it is true that a majority of individuals will fall in that category, we know that there are a lot of conditions which predispose you to tuberculosis. So let's talk about diabetes, for example. So about 100 million individuals in this country have diabetes, and an equal number have pre-diabetes. And if you do have diabetes, there is a strong risk of getting tuberculosis. If you smoke, you have about a 2-fold to a 3-fold chance of getting tuberculosis, and somewhere about 10% of individuals in India smoke tobacco in some form. If you have other lifestyle diseases or non-communicable diseases, such as liver diseases or kidney diseases, that makes you more prone to getting TB as well. So these are diseases very often of affluence. It's not necessarily of people who are impoverished. And as Indians get more prosperous, more non-communicable diseases, it's only expected that TB will also rise. The second issue with TB is that it very often gets diagnosed late. So individuals who cough, 50% of individuals in this country will approach the private sector. The private sector very often will treat you with antibiotic after antibiotic, and the diagnosis often gets delayed a couple of months down the road. And these couple of months is when you go around spreading the disease, unfortunately, to others. So I think a combination of an increase in risk factors in the country and the fact that the diagnosis is very often made late is what's contributing to the resurgence.
And am I right, Dr. Pinto, that 40% of this country is actually infected with TB, latent TB, don't know about it, and the trigger factors are the ones that you mentioned. So 1 out of 2 of us could get TB at any time. That's the point you make.
Absolutely. So TB is a fascinating germ, so you can get infected
right,
and you cannot have the disease.
Yeah.
So 40% of this country is latently infected. If you did a skin test, if you did a test called the IGRA, it'll show you that at some point of time in your life, you've been exposed to the germ has entered your body and is sitting there quietly. And during the course of a lifetime, of all individuals who are infected, about 5% of them will develop the disease. Now, when that transition from latent TB to active TB happens, is usually when your immunity is compromised because of diabetes, because of smoking, because of some other reason. So I think this reservoir of 40% of individuals who have latently infected TB are important, especially when we talk about eradication of the disease. You cannot eradicate the disease unless we somehow manage to eradicate the reservoir as well.
Now, coming to you, Raman Sankar, one of the issues that we face is in terms of diagnostics. As Dr. Pinto mentioned, many people don't know they have TB for at least 6-7 weeks. And by then it can be very serious for them. What can we do in terms of speedier tests, firstly? What is available? That's why we titled this the new treatments, new diagnostics. What can we get, instead of waiting 8 weeks for earlier sputum tests, what is the latest that we can do in terms of TB diagnostics?
Thank you, Mr. Chengappa. I think it's useful to reflect where we were around 10 years ago. We were a country which was called to have a missing 1 million or 1.5 million patients. That means that out of the estimated number of cases that are emerging, we are not actually notifying, detecting, reporting 1.5 million. Today, last year, in 2022, we reported 24 lakh TB cases. That means our case detection is improved. And this number was in 2013 or 2014 was around 14 lakhs. So our case detection has improved as a result of, newer diagnostics being used, greater awareness. This city actually gave us the TB Harega Desh Jeetega campaign, which was started by the Mumbai Municipal Corporation. And the city also gave us a model of engaging with the private sector, like Dr. Pinto was mentioning. And this is not only in Bombay, but it's across the country that a large number of people do go to the private sector for care. So it's important that we engage with the private providers, and your private providers are not only the Hindujas and the Apollos and the bigger ones, but these are also the small shops, the informal providers, the chemists. Creating a network of all those touch points has actually helped us improve the number of notifications we get to the government. And there is a way to go, and awareness seems to be the greater awareness generation is going to get patients to come themselves and actually get themselves tested.
Now, I think this is where Sudhakar Shinde could come in. Now, Sudhakar, you're also a doctor. You're also additional commissioner for the BMC. What have you all done to contain TB, in terms of both quickly getting them diagnostics as well as treatment? What is, and this could be a lesson for the rest of the country.
So, Mumbai has one of the highest number of tuberculosis cases, as well as one of the highest number of multi-drug resistant tuberculosis cases. So, BMC has done some additional to what Government of India and Government of Maharashtra is doing. So, like Government of India is having strategy of detection, treatment, prevention, and building. These are the 4 pillars of Government of India's anti-tuberculosis policy. So BMC has, in addition to it, incorporated another pillar of active search. We actively go to the door to door and do the surveillance. We do record the signs and symptoms and try to detect the tuberculosis early. Apart from this, I think Mumbai's higher number of detection of cases is also related to Mumbai pattern, which we call, and this is because Mumbai has its own pattern of collecting the data from private healthcare practitioners. Apart from Mumbai, no other unit has such kind of reporting mechanism. We have something called as patient provider agency, which provides us data and inputs from patients being treated at private hospitals. Apart from this, Mumbai has also depended more on NAT technology for detection of tuberculosis rather than going for routine microscopy, which itself has a higher sensitivity, 50% higher sensitivity.
And when Dr. Shinde is talking about NAT, this has been a revolution in terms of the molecular test. Yes. So earlier you give your sputum, but now just with a simple test of your sputum, within an hour you're able to detect whether you have TB or not. And also I'm told drug resistance, if you have, particularly for the main drug. But continue. That's why it's very critical that you spread that diagnosis. Am I right?
Regarding this drug-resistant tuberculosis, Mumbai is also taking initiative to whole genome sequencing of a bacteria so that we can treat them with a specific antibacterial drugs. Apart from that, we have also done partnership with private healthcare providers like X-ray, like collection of samples from sites other than the pulmonary sites, and these kind of interventions are helping BMC to detect more. Maybe today we are reporting more number of cases, but that also the other side is that we are able to reach out to those people and we are able to treat them better because we detect them early.
Also, one of the things that TB remains very infectious for the first 15 days of that person detecting them, probably that is infectious even earlier. Is there something that you're doing in terms of educating the people that simple things like putting a mask or, when you spit, is that on with BMC?
Definitely we are doing that, but because of the complexity of problems in Mumbai, like tuberculosis is more common among slum dwellers, where we have large number of migrant population, which people are staying in a very dense population. The ventilation, the sunlight in those accommodations is not enough to kill the bacteria which are killed naturally in other inhabitants. So we have around 1,000 bed, one of the biggest tuberculosis hospital in Mumbai, and 150 beds are reserved for the multi-drug resistant tuberculosis patient. So if we detect the patient, we tell them to isolate within their places, use mask, and if it's not feasible for them, we get those patients and isolate in our hospitals.
Now, I actually want to bring Meera Yadav at this stage. When you got TB, did you realize that you had TB? कितने महीने बाद आपको टेस्ट किया और क्या complications हुए इसके बाद? आप माइक थोड़ा नीचे, हाँ, थैंक यू. माइक.
First of all, I would like to invite me in this session. About TB, I would like to share my story in very shortly. I was diagnosed with TB in 2013 and had to undergo treatment with older drugs, including injectables. And not only I faced impaired hearing, but also limited treatment. टीबी की जर्नी जो मेरी रही है वो इट्स नॉट लाइक कि एक पेशेंट्स को टीबी होता है. ये एक पेशेंट्स को टीबी होना उसकी पूरी लाइफ को ही चेंज कर देता है. इट्स इम्पैक्ट सो बैडली. मुझे टीबी हुआ 2013 में एंड फाइनली आई वाज क्योर्ड इन 2017. सो आफ्टर सेवरल इयर्स ऑफ struggle and after being prescribed a new regimen containing that is bedaquiline and dramamine, which is 2 new drugs. तो अगर ये 2 दवाइयाँ मुझे नहीं मिली होती तो शायद आज मैं यहाँ नहीं होती. तो ये 2 दवाइयाँ मिलना कितना इम्पॉर्टेंट है एंड करेक्ट जो डायग्नोसिस है वो मिलना बहुत ज़रूरी है. 5 ईयर के स्ट्रगल में मैंने काफ़ी कुछ खोया है टीबी से एंड नाउ माई लाइफ इज़ टोटली चेंज्ड. बट येस, मैं ये मैसेज देना चाहती हूँ कि टीबी अगर होता है तो उसका जो एक्सेस है ट्रीटमेंट एडहेरेंस वो टाइम पे होना बहुत ज़रूरी है. प्रॉपर डायग्नोसिस में बहुत डिले होता है जिसकी वजह से एक पेशेंट्स की टीबी जो है काफ़ी बिगड़ जाती है हद तक, जिसे ट्रीट कर पाना बहुत मुश्किल होता है. जैसे कि अगर मैं बात करूँ तो एमडीआर टीबी क्या, एमडीआर टीबी में जिसमें बहुत सारी दवाइयाँ पेशेंट्स के इलाज में काम नहीं करती है तो मल्टी ड्रग रेजिस्टेंट हो जाता है. एंड मल्टी ड्रग रेजिस्टेंस को भी अगर ठीक से ट्रीट नहीं किया जाए तो इट कैन बी कन्वर्टेड इनटू एक्सडीआर. तब और भी ज़्यादा प्रॉब्लम होता है उस टीबी को ठीक कर पाना. सो बहुत साल सफ़र करने के बाद में इवन आई हैड टू सर्जिकली रिमूव वन ऑफ लंग्स ड्यू टू टीबी. तो मुझे एक लंग्स नहीं खोना पड़ता अगर मेरा डायग्नोसिस सेम करेक्ट टाइम पे होता तो ये है.
Let's give a very warm round of applause, ladies and gentlemen.
Thank you.
I think Meera made several significant points. One is, every TB patient has to end up taking an average of 20 pills over a period of 9 months. That's a lot of time. And that's why if you don't take them regularly, drug-resistant TB grows. Now, can you tell us, Dr. Pinto, what are the newer drugs that are coming? Some of the older drugs, they devastate your system as she was describing. Because while it's helping you, but it's also side effects are tremendous. What's new in TB treatment that we can offer and subsidize? The main thing is those drugs are expensive. How can we bring it across the country and help out?
I think the big leap forward in the treatment of multi-drug resistant tuberculosis was having an all-oral regimen. Individuals earlier would have to have daily injections for 6 months. Those injections were a significant volume, would hurt you a lot. One of the side effects was losing your hearing, which was reasonably common. And there was this loose thing that was just thrown about that you better be deaf than dead. We would trivialize that. There were drugs which were extremely toxic in terms of tolerance. I think what's really changed is the newer and shorter regimen. So it's no longer 2 years. There are regimens which are as short as 6 months now, which are all oral. So there are no more injectables. So there's something called the BPAL regimen, which has been tested with 3 new drugs. There's bedaquiline, there's pretomanid, and linezolid. So bedaquiline is easily available, reasonably easily available in India now. I think pretomanid hopefully will come to us soon through the program. And linezolid is something that's already available. So this will definitely shorten the duration of treatment. There is also a move called the 146 that is being looked at. So 1 month of treatment for latent TB. So if you're infected but don't have the disease, we eradicate that reservoir. 4 months of treatment if you have sensitive TB, that's the routine TB, as opposed to 6, which it currently is. And 6 months versus the 2 years of treatment if you have multi-drug resistant TB. I think these are very exciting days for tuberculosis in terms of the research and development. We didn't have a new drug for almost 30 or 40 years, I think. The first new drug just came out in around 2010, which was bedaquiline. But now there is a pipeline, and hopefully there will be more regimens which are tested and more drugs which will come onto the horizon, which will make lives of our patients a lot easier.
Just one ABC question, which I think will help all of us. How do you know that you have TB? What do you need to do if you are, infected, and how quickly do you need to get to a doctor? What are the symptoms? I think that'll help a lot.
So I think the 3 cardinal symptoms that we generally look for is cough, that's more than 2 weeks, if you have a fever that isn't going away for some time, and if you're losing weight without any other reason. So these are the 3 basic things that one needs to look for. The second thing that commonly gets ignored is if you have a cough and you go to a physician, the physician gives you treatment. If you're not better, don't just keep jumping physicians. Maybe sensitize your physician to the possibility of TB. Maybe be a little more proactive and ask the physician, could this be TB? If you do have a cough that's productive, you just need to produce a simple sample of sputum. So there's no injections, there's no blood draw, there's nothing fancy. A sputum sample can diagnose TB in as less as 2 hours these days. Once upon a time, we looked at it under the microscope and we missed about 40% of individuals. So it had a sensitivity of 60%, we missed 40%. With the gene expert, with the newer molecular tests, we pick up about 90 to 95% of individuals if they have pulmonary TB. Now, if TB is outside the lungs, then it gets a little more challenging because your symptoms may be slightly different. If you have a swelling in your neck, which is very common, what we call lymph node TB is reasonably common in India. You can have bone TB. You can pretty much have TB from head to toe in any organ. So anything that's prolonged, that's not getting better, don't subject yourself to antibiotic after antibiotic after antibiotic, or cough syrup after cough syrup, or different experiments. Always test for TB. I mean, it's as simple as giving a sputum smear. Why would you not test?
Excellent advice. Let's give Dr. Saab a warm round of applause for that. And Raman Sankar, I want you to look at the fact that what he said. How do you deal at a national level. What does India need to do? Very quickly, we're just 2 minutes. If you could say 2 or 3 things that India needs to do to ensure that whatever the new developments, new diagnostics and treatments that have happened can be spread at a cost-effective manner and accessible.
So I think just taking it from the awareness question, the ICMR did a survey and they found out that 64% of people who had symptoms of TB did not actually go and seek care.
64%?
So 64%. So there were a various number of reasons for it, but the lack of awareness about symptoms and where they can go and seek care was actually not available. So if we can make information more readily available, make it more easier to consume, even probably direct people to where they can go and get themselves tested, for example, can make a whole world of difference. With COVID, we could actually just tap into, we could just tell our district, our block, and, find 10 centers where we can go and get ourselves vaccinated. Why can't we do it for a respiratory illness, which is so
you would want a
widespread?
TB net kind of a network, so you can actually track people.
Yes, it should be as simple as where's the nearest TB center, and you drop down and you're actually able to go and find that. The other piece on detection actually that you were asked earlier, today there are options of computer aided diagnosis. You have handheld AI using X-rays that frontline health workers can actually go into the community, do a quick scan, and they get the accuracy of that is so much higher, and you don't need a radiologist to actually read the piece, etc. So these quick measures can also really make a world of difference. And like Sir was saying from the BMC, they're actually going into homes and doing it. So can you use those mobile X-rays aided by AI to really fast track this whole process?
In fact, the fact that you mentioned it, I know Dr. Naresh Trayan of Medanta, who actually provides these. He's got a mobile clinic with these, super fast diagnosis, and I wish more people did that. But Dr. Shinde, we have very little, 30 seconds. Yeah. The lessons that BMC learned, 2 points that you would say that the rest of the country could pick up.
I would like to urge all people present here and through this platform of India today, that first thing is that we should not have taboo about the tuberculosis. We should treat the people with tuberculosis very properly so that they come forward for the treatment. Second thing is that we should be more vigilant and try to report the cases which may have around us, like our maids, our drivers, and try to get them into the formal channel of detection and treatment. And third and most important thing is that Honorable Prime Minister has launched very ambitious program of Nikshay Mitra. Tuberculosis is a disease of poor nutrition. So if you are able to afford to provide nutrition to one person per month, around 1,000 rupees per month, that person will be named as Nikshay Mitra. And this support of this person for his nutrition is going to definitely take his nutritional level above, and it will automatically help him to fight the tuberculosis.
Wonderful suggestions. Last word, Meera, your experience, ek shabd bata diye.
As we heard about Dr. Pinto, Dr. Pinto said BPAL regimen, about BPAL regimen. I don't know how many people are aware about TB. Like if I'm talking about BPAL regimen is very shorter regimen, less duration and free injectables. And the most important thing is zero stigma. अगर हम सब के बीच में BPAL regimen available है, guidelines में है, then why we are giving longer treatment to the patient? 18 to 24 months का treatment दें या 6 months का treatment दें? What patient choose? Patients के लिए क्या सही है? तो why we are not focusing on the BPAL regimen? मुझे लगता है हमें BPAL के ऊपर फोकस करना चाहिए. And हम TB को कैसे eliminate कर सकते हैं? Is that possible to eradicate TB by 2025? या इंडिया को हम फ्री कर पाएंगे? ऐसा हम सब जानते हैं कि अभी नेशन वाइड दवाओं का स्टॉक आउट चल रहा है, दवाइयां अवेलेबल ही नहीं है. एंड वी ऑल नोज अबाउट द सेकेंड रेजिमेंट जो है, सेकेंड लाइन ड्रग्स, विच इज नॉन अफोर्डेबल फॉर मिडिल क्लास फैमिली. तो अगर दवाइयां जब अवेलेबल ही नहीं होंगी तो हम पेशेंट्स को कैसे ठीक कर पाएंगे एंड टीबी इरेडिकेट कैसे कर पाएंगे? तो माय दिस पॉइंट इज दैट मैं मैसेज देना चाहती हूँ हमारे इंडियन गवर्नमेंट को, प्लीज ब्रेक द मोनोपोली, प्लीज ब्रेक द डिलेड सिस्टम, delayed diagnosis, and break the mechanisms.
Excellent. Thank you very much. Ladies and gentlemen, let's give them a very warm round of applause.